Hello and welcome to Crash Course. Today we're going to be looking at the first year cardiovascular revision part 3. So in the first video we looked at the basic principles of the cardiovascular system alongside anatomy and embryology. Then in video 2 we looked at innervation of the heart and the blood. And then in this video today we're going to look at histology of the heart alongside the cardiac cycle and the basic ECG interpretation, and to finish we'll have some multiple choice questions. So let's get started with histology. Which one of these do you think is cardiac muscle? Is it A, B, or C? Well, the answer is C, because A is skeletal muscle, B is smooth muscle, and then indeed C is cardiac muscle. And cardiac muscle is really unique because it's responsible for the electrical stimulation that leads to that proper mechanical function of the heart. It's got 5 characteristics that are most important. It's got automaticity, which refers to the ability to spontaneously generate an electrical impulse. It's excitable, which means that the cardiac cells have the ability to respond to an electrical impulse. It allows conductivity, which allows for the transmission of the electrical impulse to another cardiac cell. It has contractility, which refers to the ability to contract after it receives an electrical impulse. And lastly, it has rhythmicity, which means the cell has the ability to send electrical impulses in a regular and evenly paced manner. So cardiac muscle, as we've already established, is also known as the myocardium, and it's an involuntary striated muscle. It's made up of cardiomyocytes which are joined together by these intercalated discs and then encased in collagen fibers and other substances which form the extracellular matrix. The muscle contraction occurs due to an action potential, when calcium is released from the sarcoplasmic reticulum and causes excitation-contraction coupling. And this can be summarized in a nice diagram. So calcium enters the cell. Intracellular calcium concentrations increase when calcium enters, and it's released then also from the sarcoplasmic reticulum. And what's really important is that it's the calcium entrance into the cell that causes that further release from the sarcoplasmic reticulum. The calcium that's then in the cell binds to calmodulin in step 2. Then this calcium-calmodulin compound almost activates the myosin light chain kinase. This phosphorylates light chains in myosin heads and increases the myosin ATPase activity. This consequently allows the actin and myosin to slide against each other, slide along the actin, and create muscle tension. And this is what leads to the excitation-contraction coupling and the sliding filament theory in terms of how the cardiac muscle works. So cardiac muscles have very special features. They're shorter and thicker than any skeletal muscle cell, and they never tire. They branch out like the letter Y, and they're linked by intercalated discs, which have gap junctions which provide a source of communication between the cells through these channels. The T-tubules are larger in cardiac muscles than skeletal muscles as well, and this allows a greater influx of calcium ions from the extracellular fluid into the myocytes in step 1. Unlike skeletal muscles, the cardiac muscles are autorhythmic because they contract independently of the nervous system, and it has their own intrinsic rhythm, which was covered in part 2 of the video, which allows it to continue beating. Now to move on and look at the ECG. Very simple interpretation allows us to understand that this is the P wave, this is the QRS complex, and this is the T wave. But what do each of those stand for? Well, the P wave is atrial depolarization. QRS is when the ventricular depolarization occurs, and this masks the atrial repolarization, which also happens at this time, but the ventricular depolarization is so great that that's what's recorded on an ECG. Then you have a T wave, which is the ventricular repolarization, and every now and again you may get a U wave, but we don't really know what that's caused by. The cardiac cycle is something you need to be aware of, but 2 simple concepts first. When we looked at blood pressure earlier, we talked about systole and diastole. Well, systole is the phase of the heartbeat when the heart muscle contracts and pumps blood from the chambers into the arteries. Diastole is the phase of the heartbeat when the heart muscle relaxes and allows the chambers to fill with blood. So essentially we think of systole as contraction and diastole as relaxation of the heart. So the cardiac cycle. This is an important diagram that you'll see over and over, and they have several different lines which you need to be aware of what they mean. Now normally along the bottom you have your standard ECG, so you'll be able to observe your P wave, your QRS complex, and your T wave. So this is your electrocardiogram. You also need to be able to understand that how aortic pressure and ventricular pressure, alongside atrial volume and ventricular volume, vary in accordance with the ECG. So first of all, we have atrial systole. So look for atrial systole on the diagram. It's here. Okay? So the left and right atria contract and blood is ejected into the ventricles via the AV valves. So as you can see, this is just after atrial depolarization, which makes sense because it's sent that impulse and then the atria have contracted in atrial systole. So what's next? Well, it's isovolumetric contraction. So let's go back to the start. So it's this short space here. Okay? An isovolumetric contraction is when the pressure in the ventricles now exceeds the pressure in the atria, causing the closure of the AV valve, so the bicuspid or the tricuspid valve. The cardiac muscles then begin to contract, and the pressure in the ventricles begin to rise even further. And you can see this particularly by the demarcation of the blue line of ventricular pressure, where ventricular pressure rapidly increases in this isovolumetric contraction stage. Then you have rapid ventricular ejection, which is marked here in this stage, and the pressure in the ventricles then exceeds the pressure in the aorta, or in the pulmonary vessels, and the aortic valve or pulmonary valve opens to allow the blood to be rapidly ejected from the ventricles. Stage 4 is isovolumetric relaxation, or reduced ventricular ejection, so it's coming down. You can see the ventricular pressure is decreasing. So the ejection velocity begins to decline, and the closure of the semilunar valves now mark the end of this phase, so the semilunar valves are your aortic and your pulmonary valves. Stage 5 is isovolumetric relaxation. The ventricles begin to relax, and the AV and semilunar valves are both closed in this very short stage. Step 6. Rapid passive filling, so this is also termed rapid inflow. The blood that has been accumulating in the atria causes the pressure in the atria to rise above that of the ventricles, causing the AV valves to open once again, causing rapid movement of the blood from the atria to the ventricles, and around 70% of the blood moves into the ventricles in this stage. Stage 7. Reduced passive filling. This is the last part of filling, and this is the period is known as diastasis, and it might not occur when the heart rate is increased. So if someone's tachycardic, which means a faster heart rate, remember bradycardia means a slower heart rate, then this is when this period would probably be skipped out. What's really important about the cardiac cycle is being able to look at the lines on here and being able to describe each of them individually. So the ECG is quite an easy one to explain, providing you know that P wave means atrial depolarization, the QRS is ventricular depolarization, and then the T wave is ventricular repolarization. Then you can easily link that to ventricular pressure and atrial pressure, and how the aortic pressure varies as well. So remember that as the aortic pressure increases, your ventricular pressure will get greater than the aortic pressure to overcome that pressure and eject. So being able to describe each of these lines is really important in terms of understanding the cardiac cycle. Now to summarize, there's 3 questions that we did at the start, which hopefully now you know the answer to. And there are also a further 2 questions which are a little more tricky. So if you think you knew the answers at the start of this session, skip past the first 3 questions and go to the last 2. If you want to double check your knowledge, go through them again. So question 1 was cardiac output can be defined as what? And hopefully now you know that cardiac output is the amount of blood pumped by the heart in a minute, so the answer is A. Question 2 asked what is another name for the pacemaker of the heart? And hopefully now after studying the electrophysiology of the heart, you'll know that the SA node is where the impulse starts. It is also termed the pacemaker or the sinoatrial node. And question 3 was which of the following is true? And now hopefully from today's session you'll be able to justify that the left ventricle has a thicker muscle than the right, and the reason for this is that it's pumping to the whole body, not just the lungs like the right hand side is. Also, I hope you now know that veins are the only things that have valves, and that the AV valves don't have 3 cusps each, the bicuspid has 2 and the tricuspid has 3. And lastly, I hope you now know the pathway of blood through the heart, in that blood enters the left atrium from the pulmonary veins, not the inferior vena cava and superior vena cava. So now for the 2 harder questions. So question 1. What is the remnant of the fetal shunt between the aorta and the pulmonary artery? Is it A, the ductus arteriosum? Is it B, the ligamentum venosum? Is it C, the foramen ovale? or is it D, the ligamentum arteriosum? So what's really important here is exam technique. Read the question. What is the remnant of the fetal shunt? It's not asking what the fetal shunt is, it's asking what's left behind in the adult life. And it's asking between the aorta and the pulmonary artery. So think about what kind of shunt may exist here. The remnant of this is the ligamentum arteriosum. So the ductus arteriosus is what exists in the fetus to allow the shunt between the aorta and the pulmonary artery, which allows the blood to bypass the lungs, because remember in fetal circulation only 10% goes to the lungs because the vessels are so vasoconstricted. So therefore the remnant is the ligamentum arteriosum, because remember the ductus arteriosus should close at birth due to prostaglandins. Now one other question. What ion is primarily responsible for the repolarization of an action potential? Is it potassium, sodium, calcium, or chloride? So think about the sequence of an action potential and what ions are responsible for each stage. So of course the answer here is potassium, and if you think about this simple action potential which this question is asking for, depolarization and repolarization, repolarization is all to do with potassium ions, a potassium efflux out of a cell, and depolarization is a sodium influx into the cell. So that's everything for this video. I hope you found the revision session useful, whether you're first, second or third year. And if you do have any feedback, please do let me know either in the comments below or send me an email. It's greatly appreciated. Thank you very much.